Yeah, please start your session.
Good afternoon, doctors. We cordially invite you to a webinar on the role of Oseltamivir in flu management. Dr. Hetero Healthcare has brought this program. It's an innovative pharmaceutical company, and our journey began in 1993. We have 30 years of excellence with 36 state-of-art manufacturing facilities, 300 plus products in portfolio, and presence in 126 plus countries. We have 21,000 employees globally, and we are amongst the largest manufacturers of ARVs, APIs, and FDFs in the world. We have Asia's largest API manufacturing facility at ECZ complex, Visakhapatnam, Andhra Pradesh. Hetero Healthcare is 360-degree solution provider striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties, pioneering in quality and innovation. We have distinction of bringing 4 biosimilar products to market within 5 years of initiation. They are darbepoetin alpha, rituximab, bevacizumab, and adalimumab. During COVID-19 pandemic era, Hetero Healthcare, the pioneer in antivirals, offered oseltamivir, favipiravir, and remdesivir to the patients, for which in August 2020, Hetero Healthcare received Award of Pharma Excellence for COVID drugs. Today's webinar, Role of Oseltamivir in Flu Management, we have got Dr. Pramod Jog as moderator and Dr. Sanjay Nathu as speaker. Dr. Pramod Jog, sir, as we all know, is Professor of Pediatrics, D.Y. Patil Medical College, Pune, President IIP 2016, Steering Committee Member, GAVI, CSO 2016 to 19, Chairman, Mini Recipe Model IIP, and author of the book Pathology. Dr. Sanjay Nathu is MD DNB Pediatrics, MNAMS, FACEE, PEM, currently Professor and Head of the Department, Pediatrics from March 22 till date in Srimati Kashibai Nawale Medical College and General Hospital, Pune. Sir is consultant physician, Shashwat Hospital, Kothur, Pune. His area of interest is pediatric pulmonology, pediatric infectious disease, pediatric emergency medicine. President IIP Pune branch 2021. Member of Pediatric COVID Task Force Pune Division. Organizing team member of numerous national and state pediatric conferences training. Former National Academy of Medical Sciences, former academic national member of National Academy member of Medical Science India. Fellow of Academic College of Emergency Experts, Pediatric Emergency Medicine, member of Indian Academy of Pediatrics, Indian Medical Association. With this brief introduction, I hand over the session to Dr. Pramod Jog for further deliberation. Over to you, sir.
Thank you. Thank you, Dr. Prashant, for those kind words about me and Dr. Sanjay. Dr. Sanjay is a brilliant academician in Pune, and we will have a discussion. I will be presenting a few points related to flu, and today's topic for discussion related to Oseltamivir, which is one of the important antivirals. I will just start sharing my presentation. So Sanjay, are you able to see my presentation in full screen?
Yes, sir. Yes, sir.
Thank you. So, as I said, today we have a genius pediatrician, and the program is by Hetero. So I always say it's a heterogeneous program with Dr. Sanjay Nathu. And you can see that my name has been put in the style of influenza virus, because we all describe influenza virus as the place of origin, the month and the year of origin, and the strain. So we should all rehearse, by putting our own names in the style of influenza virus. Of course, I was the strain of IIP presidents in the year 2016. And basically, the monsoon is in full swing, and we are witnessing the rains in cats and dogs. And we all know that there are different entities who are very happy with the onset of monsoon. The farmers are happy for the crops. The frogs are happy. They come out of the hibernation. The doctors are happy because the OPDs are in full swing. And the pharmacists are also happy because the sale of medicines is in full swing. But the parents are not happy because the children are not well. And we are witnessing cases of flu-like illness, different viral illnesses, including dengue, influenza, and so on and so forth. So whenever a patient comes and asks me, sir, is it viral? And after examination, I say, yes, it appears to be viral. On one side of my mind, I am always worried, because if it turns out to be some dangerous viral illness, then it's a tough task for me. For example, a child with mild viral illness to begin with today, if it turns something different after 3, 4, 5 days, for example, dengue, we all know that on the day 5 or day 6 or around that time, day 4, 5, 6, it enters into another phase, which is immune based, and then the child may worsen. So I always make it a point to call the patient after 4 or 5 days, because if you say it's viral on day 1, and the parents get relaxed, okay, there is nothing to worry, Dr. Jog has said that it's viral, so he goes back with complacence, and then he doesn't come back. But I make it a point to tell him that you have to come back after 4 or 5 days, because I would like to know the progression, whether this child has really recovered, whether his fever has worsened, whether he is going into another phase which is immune based, whether he is developing rash, and so on and so forth. So many things are to be seen. Sometimes there is no localization on day 1. So when you say viral, beware that this virus may take some other turn, and that's why please call the patients for follow-up. And the best way to ensure that they come for a follow-up is not to charge them for the follow-up charges. If you tell them that it is for me, I am learning, so when the patient comes back, I learn. When I say that the illness is biphasic, then I want to see whether it is really turning into a biphasic illness. And these things are very difficult to be seen on day 1. Okay. So when there is a 3-year-old boy coming for fever, cold, cough, and progressive breathlessness over 3 days with tachypnea and low saturation and pH showing 7 with an X-ray picture like ARDS, getting admitted to PICU, getting ventilated, and receiving Oseltamivir after 3, 4 days of onset of the illness, along with supportive therapy, who turns out to be H3N2 positive and gets ventilated for 3 days and then recovers. One always thinks whether I could have avoided these complications by starting Oseltamivir early. Okay, so a previously healthy child presenting with cough, cold, and fever, progressing over 3 days, and the treating physician, whether he could have prevented this progression. So that is the question. Okay. And that brings us to an important question, whether every patient of cough, cold, and fever be given Oseltamivir upfront, particularly in this flu season. Okay. And that's why there are many points related to flu, which I would put as points of confusion related to flu, whether it is bacterial or viral. If it is viral, which is the virus, whether it's rhinovirus or RSV or adenovirus or influenza or parainfluenza. If it is influenza, whether this is H1N1 or H3N2 or any type B, or whether I need to start Oseltamivir upfront, and whether I should give every patient an antiviral to play safe. So let us have a bit of a background before we start our discussion. So there are many healthcare related challenges in monsoon. And we have one pandemic in 2009, the COVID-19 pandemic, which lasted from 2020 almost to 2022. And we know that influenza in India is associated these days with rising number of cases, rising hospitalization, and deaths also. And this virus is of 3 types: influenza A, B, and C, of which all the epidemics and the periodic pandemics are related to influenza A. Okay. This influenza A virus, it has, H and N glycoproteins on the outer side. And these H and N are useful for the virus to get attachment to the respiratory epithelium. As I told you, there have been 4 major global pandemics of influenza. The first one was in 1919, then 1957, then 1968, and then 2009. So this virus gets transmitted by droplets, and it enters the respiratory system of the person in front who is in close contact with the person who is coughing or sneezing. And as I was trying to tell you about the hemagglutinin and the neuraminidase, H and N glycoproteins, remember that the virus gets an attachment with the uh, respiratory epithelial cell as depicted in this particular figure, so that hemagglutinin allows the virus to get attached to the respiratory epithelial cell. The RNA virus, remember, influenza and COVID both are RNA viruses, and they are very naughty viruses. Why naughty? Because they change their structure every year. Okay, and sometimes, as I told you, during pandemics, they suddenly undergo a major shift in the the composition of the proteins on the outer surface. So hemagglutinin allows the influenza virus to get attached to the respiratory epithelial cells. The RNA is the one which enters into the respiratory epithelial cells. It multiplies, and then the virions, the virus particles, they want to come out of that cell. So they get, collected at the entrance, that is the cell, outer part of the cell, ready to get outside. And with the help of the enzyme neuraminidase, which splits the attachment with that sialic acid at the exit gate, that is the one where exactly oseltamivir acts. We will see more details about it. So the release of the new virions from the respiratory epithelial cells is prevented by the use of oseltamivir, which is a neuraminidase. So I was trying to tell you that this hemagglutinin is the molecular key. That means it is the key for the virus to enter into the respiratory epithelial cell, while neuraminidase is a scissors. It will cut the connection or the bond between the sialic acid, allowing the viral particles to get outside and attack other respiratory epithelial cells. Okay, so this is very important, and we all should remember that once you block the exit of these virions from the respiratory epithelial cells, the other respiratory epithelials will not get affected, so the progression of the disease will be halted. Okay, and that's very, very important. Of course, we all are aware that there are different illnesses coming with similar presentation. So, many times we call as influenza-like illness. Sometimes we have H1N1, sometimes we have severe acute respiratory illness, sometimes we have COVID-19, and fever and myalgia and cough and weakness and sore throat, all are very common. And we all have witnessed children with H1N1 as well as severe acute respiratory infection and COVID-19 getting breathless. We have witnessed COVID-19 cases losing their sense of smell and taste. We have seen influenza cases as well as COVID-19 cases coming with diarrhea, particularly in children. And remember, the cases of influenza which come to us, they have three things in common. They have extreme headache. Of course, the onset is with very sudden onset of high fever, and the child will have headache. Usually, children don't complain of headache. So they have weakness. In fact, to such an extent that the parents, they lift up the child who is 9 or 10 or 11-year old and bring to the clinic, and they have muscle pain. So a child who never complained of headache or saying that my legs are paining, he's the one. If he complains of these, then he is probably having influenza, and I call this as a systemic illness. And it is the father of all those influenza-like illnesses. But one should be aware that flu, when we had a notion that when you say flu, usually people take it out. Flu to hai, it's only flu. What is there to worry? But no, there are certain things which one must worry, even though it is flu. So when a child breathes very fast, when of course he has cyanosis, when he is not drinking enough fluids, when he is not waking up, or whether he is so irritable that he doesn't want to be held also. So all these are important, clinical symptoms and signs one should be aware of when he is handling a child. So these things must be explained to the parents. Otherwise, parents, they just go home saying Dr. Jog has said that it is flu, nothing to worry. No. So these things, these 4 or 5 things must be written on the prescription paper. If you don't have time, please ask someone to write down that if these 4, 5, 6 things are there, then please report to us back. And of course, the best thing is, to call them for a follow-up in the next 4 or 5 days. And one should be aware that flu is not so simple. So it has complications which would start with the alphabet A in the form of acute respiratory infection, which could be pneumonia or ARDS, acute otitis media, absenteeism for children from the school, or affection of the amadani, that is the income of the parents, and antibiotic abuse. So all these are important complications, and of course these complications can be prevented by preventive measures as well as vaccination, and also early use of oseltamivir. And treatment typically is divided depending on the category of influenza. We all know that influenza is traditionally classified into category A, B, and C, where A is the mild form, wherein the child can be managed with bed rest and increased fluids and symptomatic treatment for cough and fever. But as the child goes into stage B and C, which are associated with either breathlessness or distress or hypoxia, one needs to monitor the child. One needs to investigate. If possible, the throat swab should be done. And these are the two stages where the treatment with oseltamivir is also indicated. And as I told you earlier, oseltamivir blocks the neuraminidase, and that's why it is called a neuraminidase inhibitor. There is another one called zanamivir, which is also from the same group, and both these drugs act against influenza A and B. While there are others like adamantanes, those which block the entry into the host cell, okay? But they are active only against influenza A viruses, and they are drugs like amantadine and rimantadine. And oseltamivir is a potent and a selective inhibitor of the neuraminidase enzyme, and it's a prodrug, and it gets converted into the active form oseltamivir carboxylate in the liver, and it inhibits the influenza virus replication, as I told you, okay? And it prevents the further spread of infection. And this molecule was the first oral neuraminidase inhibitor described, and it has been approved in more than 100 countries. And our pediatric colleagues are well versed with the dosages. Basically, the child is treated depending on the weight band. So a child is under the age of under the weight of 15 kg will receive 60 milligrams in a day, and these dosages are divided into two for the therapy. Okay, and oseltamivir is also available as a capsule of 30 milligrams, so it can be conveniently given as one BD. Okay, 30 milligrams twice daily, and then up to 40 kg the dose goes on increasing. And for infants who are 2 weeks to less than 1 year of age, the dose is 3 milligram per kg twice daily. And for adults, of course, the dose is 75 milligram capsule twice daily. For chemoprophylaxis, the dosages are given only once in a day, but they are given for 10 days. It is important that we know that chemoprophylaxis is given to all those high risk individuals in the family. See, in a family, child is the main spreader. What is the basic difference between flu and COVID? Flu is transmitted from the child to the adult, okay, while COVID majoritarily is transmitted from adults to the child. So when the child is protected, the transmission from the child to the high risk individuals like an asthmatic father or a diabetic mother or a chronically ill grandfather is prevented, and then the high risk individuals are protected. Okay, and there have been quite a few clinical trials, and they are the ones which show that the empiric and the early use of oseltamivir is of great value. Particularly, it reduces the antibiotic use, influenza-related lower respiratory tract complications, and hospitalization to a great extent, and also the occurrence and the severity of pneumonia, not in children, but also in adults. And WHO has recommended empiric treatment strongly, meaning thereby the treatment should be started as soon as possible. The laboratory confirmation of the virus is not necessary for initiation of therapy, and the negative lab test for H1N1 does not exclude the diagnosis in all patients. And therefore, you have to start the therapy early. And if high risk individuals have been exposed, then one has to consider presumptive treatment, as I just told you. And remember that even the adults, as I told you, who test positive for influenza, they should be treated with Oseltamivir. Okay, so with that initial introductory, comment about influenza and Oseltamivir, now I will start with a bit of a discussion about some important cases and some important points in relation to influenza and management. So, Dr. Sanjay, many times we witness rise in the viral infections, and many times the viral infections, they come in waves. For example, hand foot mouth disease, suddenly number of patients of hand foot mouth disease increase, suddenly bronchiolitis cases increase. So over the last 4 or 5 years, maybe after 2020, with this COVID and uprise and the downfall of COVID, what is your impression in general about the viral infections? So and probably what are the possible reasons what you think of related to these variations in the viral infections?
So, good evening to everybody, and good evening, Dr. Zog sir. So, yes, I would definitely agree, as I'm sure most of the pediatricians who are practicing, that the number of viral infections which we face in our day-to-day life, day-to-day practice has gone on increasing in the last several years. Many reasons for that could be there, but one of the common things which we all know is the increasing vaccination which is occurring now in the national program as well, with the pneumococcal also being introduced in the last several years. So the proportion of bacterial infections which we face in our practice has definitely gone down. And as you rightly said, we get waves of bacterial of viral illnesses, like we have been seeing for this last 2 months or so. We are facing several viral infections, and yes, definitely the number has gone up.
Just for the information of our listeners, I would just say that even the older children are getting affected. And what we get in the OPDs these days are children with recurrent respiratory tract infections. We are getting otitis media cases, adenoidal hypertrophy, and influenza, though it's a illness of monsoon, many times we are getting unseasonal surges in influenza. We have witnessed adenoviral outbreak, and I always say that adenovirus has become a bad adenovirus because it is showing varied presentation with prolonged illness. And there are many times diagnostic dilemmas. For example, CBC, we always feel that CBC and CRP, usually they are high in bacterial infections, but even adenovirus produces rise in the CBC and the CRP. Then nasopharyngeal swab, for example, earlier we never used to do those many swabs, but then many times now we are forced to do it, either for the purpose of therapy or rational use of antibiotics, or to convince the parents that these treatment modalities are necessary. And then the therapeutic dilemmas as to what all is to be given to that particular child. So with that, Sanjay, I will just put one sample case in front of you. Is a child called Viru with fever for 3 days, having cold and cough. He has been on meter dose inhaler for the last 4 months. He has been well controlled of that. And right now, for those initial 3 days of fever, he has received some symptomatic therapy for cough and fever. But then he has come back after 3 days. Actually, he was half febrile for a day, and fever has come up again. So he has been active in between, but now again he has come back after 3 days. So now at this stage, what will be your approach? Obviously, this is recurrence of the viral upper respiratory infection, and as I told you, this has become more frequent, and it's occurring at a shorter interval. So the parents are worried that he had improved, but he is not recovering. So what will be your lookout in such a case?
So we have been seeing these type of cases quite frequently these last couple of months. Very frequent viral infections, and this is more so ever seen in children, school-going children, because there are a lot of kids in the school who are carrying the virus, keeping on spreading the virus, and younger children who are going to a creche or a play group. They are also getting repeatedly exposed to viruses and getting repeated infections. So in this case, Viru, which you showed, he's a case who is probably been diagnosed as probable asthma and started on meter dose inhaler, and he has got a viral infection. gotten better a little bit and come back again. So in the given situation, this would be more likely to be a repeat or recurrent viral infections. But at the same time, we would be a little careful while dealing with this patient, whether it's a biphasic fever of some other infection, or whether it's the initial flu, maybe which has gotten complicated with a superadded infection. So we would like to keep a close watch on this child. Though at present, I would definitely try think in terms of a recurrent viral infection.
Okay, that's great. And it's important that you convince the parents, and it's important that you counsel the parents that recurrent viral infections are common because the age of schooling has come earlier. Children start going to school right from 2.5 and 3 years, even sometimes earlier than that. And other kids, they come from different parts of the same city and they donate different viruses. So some child will donate RSV, some child will donate flu, some child will donate parainfluenza, and the child develops immunity against one virus. But by the time the child starts going back to the school, another virus is ready, to be donated to the same child, and the parents are really, really frustrated. And that is one of the important causes of changing one doctor, and that's why they keep shifting from one doctor to other. And the only point to be remembered is that these are back-to-back viral infections in majority of the cases, and the only way to convince the parents, Sanjay, I'm sure you'll agree with me, is to maintain the growth chart and just to show the parents that even though this child has been getting repeated respiratory infections, the growth is not affected. Okay, meaning thereby there is nothing serious which is there underlying these problems. Do you want to add any other point related to counseling of the parents, Sanjay?
So we are seeing in these last few days, the whole family is getting affected one by one. So the younger siblings, maybe 3, 4, 5, 6 month old babies are also getting an infection because of the elder siblings carrying it from the school. So we have to ask the family to be aware about these situations, and especially the younger children, they need to take more care. Slightest possibility of an infection, they should report to the pediatrician. And the treatment part also needs to be highlighted, because what is happening these days is that we are getting fevers which are lasting a little longer, and the parents are tending to panic a little bit more, which is obviously natural with very high grade fever and fever which are lasting longer. But then again, we have to be sure that we counsel the patient regarding the treatment, especially the let us say control of fever to certain extent, a good hydration and rest is what we would talk about to the parents.
Sure, sure. That's very good. And I always my colleagues also that panic of the parents is not an indication for antibiotic. So panic is not antibiotic. And secondly, the degree of fever in the beginning, like many times pediatricians feel that, it started with very high fever. Let us start him on amoxicillin. It's not so. Influenza, as I told you, starts with very, very high fever, and that really doesn't need an antibiotic. And antibiotics are not antipyretics. So that is, very important. Otherwise, parents get misguided, and every time what they do is, this time this pediatrician gave an antibiotic in the beginning, so next time the child gets viral fever, they again repeat the same prescription. Okay, so look at many of them. I'm sure, Sanjay, people come to you and show you, sir, this is the prescription that you gave me last time. So for the last 3, 4 days, we have tried all this, but now that is not working. So what do we do? So
And I
these
would
are
like
certain.
to add a point that starting antibiotics early, we are concentrating on hydration, maintaining a good intake. Sometimes these antibiotics themselves cause a lot of nausea and compromise the intake itself. So we get patients on day 3, day 4, as you rightly said, who have already been prescribed antibiotics, and now they are in a bad shape because of poor intake as well.
Sure. So that's very important that you counsel the parents, take little extra time and counsel them. Now there is one question, Dr. Sanjay, about identification of our enemies. Enemies means either viruses or bacteria. So I have just enlisted a few, viruses which come with a typical presentation. So maybe for the benefit of our listeners, you could just elaborate on the clinical clues to the viral infections.
Definitely, sir. So, rhinovirus is, all of us know, it's very common. It's a common cold which basically affects the upper airway, and relatively mild illness with some cold and some sneezing, occasionally some fever. but the children are fairly well throughout the course of the infection and does not affect that much. The child is not affected that much. Adenoviruses, according to the points already mentioned on the slide, like fever is there, obviously some diarrhea, mesenteric lymph nodes, but many children may also have an associated conjunctivitis with the adenoviral infections. RSV, though we all know RSV as a commonest cause of bronchiolitis, it also presents an upper respiratory infection. But yes, there are chances of developing bronchiolitis, and depending upon the degree of bronchiolitis, mild, moderate, or severe, the course may be a little difficult, but most of the times the children recover completely well. COVID-19 recently we have not been seen very commonly. Occasionally one odd case may be there. So it presents mostly as fever and dry cough, but hardly any other symptoms. And the influenza, all of us are seeing a lot of headache, lot of body ache, and high fever, especially early part, and very, very severely exhausting for the child. So these are the common things we usually see in our practice.
Sure. Maybe you can just in the same breath complete the discussion by telling something about clinical clues to bacterial infections.
Right. So the streptococci, which commonly cause the upper respiratory bacterial infections, present with a follicular tonsillitis, which is quite painful, and again tender cervical and jugular digastric lymph nodes. The pneumococcus commonly affects the lower respiratory tract, causes pneumonias. So the child may be tachypnic, may have grunting, and of course high fever is going to be there. Staphylococcus, rapid progression, and in a classical case, you would get a toxic child, sometimes with nematoceles and complicating pneumonias, which get complicated. While as an older child who is in a school-going age group, if he presents with the signs of pneumonia and a predominant cough as a symptom, then we would definitely suspect mycoplasma in these older children who are school-going age group. Sir, you are muted.
Only one small little question. Many times parents come to our clinic saying that the child has fever, the child has cough, cold, the child has diarrhea, and then the pediatrician is really, in a fix as to what to do. Whether this is something respiratory or whether it is something related to the GI or whether it is viral infection which is affecting multiple systems. So the question is whether this influenza as a presenting feature can come with viral infection which is associated with cough, cold and fever along with diarrhea. Is there something which you would like to share about this particular clinical presentation of influenza in children, whether it differs to some extent from the adults?
Right. So in general, viral infections tend to affect multiple systems as a thumb rule. So if you're getting upper respiratory involvement with a lot of prostration, malaise, as well as a gastrointestinal involvement, then you definitely suspect viral cause and the influenza which we are seeing. Few of the children are also having these loose motions, some presenting with vomiting. So yes, influenza can present with this type of picture as well.
Sure. So we have a case. He's a 4-year-old child with cough and fever of high grade for the last 5 days and not settling with oral medicines. And on admission, the child has tachypnea and needed oxygen support. As you can see, the X-ray is showing the involvement of the right side of the lung. The total count was 1620. The platelet count was 132,000. HGPT and HGOT were on the higher side, and the nasopharyngeal aspirate was positive for H3N2. So this is a case where this child has come to us with influenza with low WBC and low platelet count. Sanjay, will you like to elaborate a bit more about this presentation and these investigations, particularly in this season?
Yeah, so this child has got fever, which is high grade. It's almost 5 days now, and it is not settled with some whatever oral medicines he has received. And the X-ray, which has been done, also is showing a lot of infiltrates, more on the inhomogeneous infiltrates on the right side, as well as few in the middle and lower zone in the left side as well. And he's now tachypnic, needing oxygen support. So this child definitely, obviously needs an indoor admission. And his lab is showing a picture of leukopenia with some amount of thrombocytopenia as well and raised transaminases. So the liver is also affected to some extent. Fortunately, we have a diagnosis of H3N2, and if you are aware of the epidemiological situation right now, H3N2 is the predominant strain which we are getting in many of our patients right now. So this child is conforming to that finding as well. So yes, it is an influenza with a low WBC and low platelet, and most of the pediatricians would agree that if you do a lab test of these children with fever, which is lasting for 3, 4, 5 days, you are very likely to get this leukopenia and thrombocytopenia in this situation. So yes, this child deserves, of course, the treatment for influenza, which is going to be oseltamivir, which will be given orally. Whether I would also start an antibiotic is a difficult question, but yes, I would probably think of starting an antibiotic with the fact known that there is going to be a subset of patients who are likely to get complicated with an infection which is going to go on top of the influenza. So around 15 to 20% of patients of influenza may have a superadded infection bacterial as well. So one can think of adding an antibiotic to oseltamivir in such a situation. Sir, please unmute.
Yes, I am sure that you will also observe this particular child on day 4 and day 5 because we have been witnessing some cases of dengue fever also, and these children can present with leukopenia and thrombocytopenia. And for a surprise, one should not get caught up in the diagnosis of dengue, though here the diagnosis has already been done by the nasopharyngeal aspirate. But it is prudent and wise to observe these children because leukopenia and thrombocytopenia are important indicators related to even dengue. So all these points are very important, particularly on day 5, and that is what we have been stressing right from the beginning, that see that children are seen again on day 4 and 5, so that you can rest assured that this child is definitely recovering, not getting worse. Okay. So now, as you already said, that oseltamivir should be started. Of course, here the investigation report shows H3N2, but then if the report would have been negative, would have started oseltamivir empirically, Sanjay? Would you have started?
Probably yes, because of the epidemiological situation right now, where we are seeing a lot of patients with influenza, H3N2, and some other viruses, but mostly it is influenza. But in such a situation, I would definitely think of doing a dengue to rule out the presence of dengue or confirming the absence of dengue. And then, yes, oseltamivir empirical in such a situation would definitely be warranted.
Very good. That's important because, as we said earlier, whenever a child with fever and cough with breathlessness, this child has tachypnea, and that goes straight away into grade rather B. And this is one of the indications for oseltamivir. And that's why, even though the reports are negative for H3N2 or H1N1, one should put this child on oseltamivir empirically. And this is another child with H3N2, where again fever was there for 5 days and fever was not settling. Of course, the counts here were normal. Another child with H3N2 with cough, cold, fever, normal counts, but CRP of 38. And just wanted to know, Sanjay, as to what are the factors on which the clinical response to oseltamivir depends?
So, all types of influenza, that is A and B, which we commonly see, both of them respond well to oseltamivir. The one factor which has been mentioned in literature, which is going to define whether how the response is going to be, is how early we start oseltamivir. So, if it is started in the first 48 hours, then we are definitely likely to see a very good response to oseltamivir. So, early starting oseltamivir is very important. Having said that, that doesn't mean that you should not start oseltamivir late, because many times children come to you third, fourth, fifth day. You can see that it is behaving like a typical influenza, and it is never late to start oseltamivir. That is what I feel, because we also tend to get good results even though we start oseltamivir a little, maybe not within 48 hours, but a little later than that as well.
And then, of course, there are, reports and articles which support what you say, that even if you get a child after 5, 6, 7, 8 days, and the child is diagnosed to be a case of influenza, it is prudent and wise to start oseltamivir because it reduces the rate of complications and the mortality. Now, going ahead, we will discuss another child Of course, this child came as a surprise. He was 4-year-old with cough and cold. But as I said earlier, this child had high WBC count and high CRP, and he had continuous high fever, and the nasopharyngeal aspirate showed adenovirus positive. So don't be surprised if you get suddenly some other, virus in the report. And this child, Ria, 5-year-old girl with high fever for 5 days, with cough and cold for 5 days, but looking sick and getting mild wheezing and no crepitations. So, in view of this particular presentation, will you like to put this child on antibiotics after 5 days of this particular illness persistence?
The child is present with cough and cold. So usually colds are less likely to be because of a bacterial origin. Most likely it's a viral thing. I would like to find out how the child is in between the febrile episodes, whether the child is stable or very sick during the interfebrile episodes. And then depending upon that, I would decide whether I need to think of starting an antibiotic or I can just hold on, counsel the patients and keep the child on a close follow-up. Probably I would investigate this child since it's a fever of almost 4 or 5 days now. I cannot just wait and think of it as a viral. So I think the investigations have shown
Yeah.
that the WBC count is low with a predominant lymphocytosis and CRP is 34. So
Yeah.
then again, this does not fit in with the bacterial picture as such. And I would, again, with the epidemiological situation, think of starting Oseltamivir as an empirical therapy.
Right. And thing was done. However, the nasopharyngeal swab showed rhinovirus as a positive virus, and that brings us to another question, which is very important. That when you send a nasopharyngeal swab and you get some other virus and not the influenza virus, we always start thinking as to what is the sensitivity of this influenza PCR, because on one side we are having a suspicion of influenza, but the reports are not showing that. So, what is your personal opinion about this PCR test being done on the nasopharyngeal aspirates, or the nasopharyngeal swabs rather? Yeah.
Right. So in certain situations, we need to do the nasopharyngeal aspirator swab test, which is true. And some viruses, which are, if isolated, are usually like acceptable or reliable reports. For example, influenza or a parainfluenza or adenoviruses. Sometimes they can be isolated, though. Having said that, they can be commensals also sometimes. For example, adenovirus can be a normal commensal as well. So you have to correlate with the clinical situation and then decide whether the test is to be ordered. And if it is to be ordered, some viruses like a Boca virus, for example, if isolated, would not be of any significance at all. So depending upon what the viral test results show, we have to correlate it with the clinical situation.
So it is very important that you have to weigh the situation depending on the clinical presentation of the child. However, one has to remember that viruses like RSV and influenza together may complicate the clinical picture, and we will see some cases which presented with presentation like dual viruses presenting together. Of course, this particular child was a daughter of an IT sector parent, and as you know, IT sector means not only information technology, but inquisitive and troublesome sector. So we are all worried to have such patients. And usually they come with their own laptops. They keep it on my own table and they start asking all those questions. And many times they are well read. So on one side, it's a great experience to answer these people. But on the other side, they take a lot of time. But of course, we have to bear with that as a part of our profession. Anyway, so this particular, patient came with this 7-year daughter with high fever, throat irritation, and parents saying that she has an exam after 2 days, but the throat was only showing mild congestion. Okay, so she was given paracetamol, but with the flu and the adeno and all these viruses, roaming around, the problem is as to how do I manage, looking into the status of these parents and all these presenting symptoms. So, Sanjay, how would you manage such a child?
If you go back to the case, the child is a 7-year-old child with fever for 3 days and typical throat irritation and some throat congestion. So, if you look at the guidelines for use of oseltamivir, this would not fall in the category which would require empirical treatment. It would just require symptomatic treatment. Yes, flu is in the environment. We know adeno is also, may also be there. So only symptomatic treatment is all I would do for this child with, of course, good counseling and a close watch. So follow-up would be required. Maybe after 48 hours, we'll have a look again to decide whether the child is improving and if we need to do anything further.
Wonderful. So going from the guidelines, when such tricky situations trouble you, remember A, B, C of the grading of this disease. This is typically a case in grade A, and that's why no breathlessness and no distress and no hypoxia. So neither the throat swab is indicated, neither empiric oseltamivir is indicated in this child. Okay, and observing this child is very, very important. And of course, Sanjay, we would like to know as to when you start oseltamivir, how long usually do you administer? Because I have seen some adult physicians prescribing oseltamivir for a longer period, not restricted to only 5 days. So, what is your own experience?
Usually, we prescribe oseltamivir for 5 days. That is the recommendation. When we are treating a child, especially a confirmed case, when we are thinking in terms of prophylaxis, then we would like to give it for 10 days, but then the dosage in that situation would be a once a day dosing for 10 days. While treating, it is for 5 days, twice a day dosing. I'm sure all of you will remember during the pandemic, there were cases who were confirmed H1N1 positive and who were in the ICU or were severely ill. In those patients, a longer duration of oseltamivir was justified or was recommended. But at present, what we need to do is treat the influenza with oseltamivir for 5 days.
Sure. And this 3-year-old boy coming for cough for a week and high fever for 3 days with crepitations, treated with coamoxiclav and getting admitted for persistent fever. Okay. Put on IV augmentin with a WBC count of 7,750 with neutrophils 49, CRP of 2.8, and throat swab showing influenza A, and oseltamivir being added depending on the report. Now, already the child is on IV amoxiclav. So, with such a report, would you stop the antibiotic that has already been started, or what would you do?
So, as I have repeatedly said, you have to be aware of the epidemiological situation in your area. If the predominant things which are going around in the environment or in the patients are a viral influenza, which is quite rampant these days, then even a child who has crepitations with a lower respiratory type of presentation and which has started with cough and cold with some other household family members also getting affected, I would still think as a viral as the first cause, especially if the test has come positive for the nasopharyngeal swab has come positive for influenza, I would definitely think of stopping coamoxiclav and continuing oseltamivir, and of course keeping a close watch and see the response to oseltamivir whether the child has improved or not.
Sure. So, in case if the child is not worsening and if he is not sick and he is showing all the signs of stability, hemodynamic stability, there is no harm in discontinuing this amoxiclav which has already been started. But it all depends on the individual case, because we all know that 25% cases of influenza can be associated with bacterial infections like pneumococcus or staphylococcus, and one has to be aware. So one has to observe these children, but at the same time be rational. And many times this is a difficult decision, but then one has to weigh the situation and decide depending on so many things that we have described. So the question is again the one that we have been discussing right now is whether in case if you are prescribing antibiotics concurrently, whether to continue or discontinue, and we have just addressed this particular question because it's a part of antibiotic stewardship. At least one should not escalate the antibiotics unless they have some proof of the organism, either in the form of PCR positivity or some bacterium which has been detected after the throat swab. Okay, and now one additional problem many times is that elder sib is already coming to you for therapy, and the mother calls you up in the evening saying that even the younger sib is now getting high fever for a day, and now they want to take your telephonic consultation that you have already started oseltamivir because this elder child was suspected to have flu. So shall we on our own start with oseltamivir because the younger one is close contact with the elder one? So how do you handle the situation whenever you come across other sib in the family getting symptoms?
Right. So younger sheep are definitely going to get exposed and get catch the virus as well. Now, I would definitely ask them to get the child to the OPD because I would like to have a look. They are right in thinking of giving oseltamivir. Even the guidelines, if you look at them closely, would also recommend that because with this age of 8 months, this child would fall in a category B. So in category B, they say that children less than 5 years, and especially if they are less than 2 years, you can think of starting empirical oseltamivir even without doing the diagnostic test, given the epidemiological situation, especially with a sibling who has already been diagnosed with influenza. So I would have a look at the child and probably yes, I would start him with empiric oseltamivir. I would not want to go for testing for this child with the older sib already diagnosed.
Okay. And of course, there are a few cases. One of these cases is, a 1-year-old child with fever, cold, cough, but coming with status epilepticus and the nasopharyngeal aspirate showing H3 and 2, and the MRI showing non-specific changes of encephalitis with CSF normal. And this child was diagnosed as a case of influenza encephalitis. So the neurologic manifestations or other complications related to influenza include simple febrile convulsion, influenza-associated encephalopathy due to cytokine dysregulation, acute necrotizing encephalitis, Guillain-Barré syndrome, and aseptic meningitis. So one has to be aware that influenza may not be that simple. Okay, and of course there are a handful of cases witnessed, where there was a presentation with fever and headache without any clear focus, and then these children, they turned out to be turned out to be cases of influenza. Sanjay, I just wanted to know your experience about any major adverse effects related to oseltamivir in your practice and whether it is well tolerated.
We have been using oseltamivir quite frequently, especially this year, and fortunately, the medicine is quite well tolerated. The only precaution which I tell all my patients is to take it after food because it can sometimes cause a little bit of gastritis if taken on empty stomach. But otherwise, yes, the children are tolerating oseltamivir very well. Hardly any major adverse effects have been seen.
Yes, and it is very important that the medicine is retained in the GI tract because that's the medicine which is available only in the oral form. And one has to see that by the use of either antiemetics or proton pump inhibitors, one should see that the child retains the medicines in the system. Okay, and of course, this particular case was a case of influenza H3N2 with RSV, and there was another child who also came with influenza with RSV. So one has to be very, very careful that you may find two viruses, but in case if both of them are known to create a rather much more severe presentation, one has to see that influenza is taken care of with the help of oseltamivir, so that the viral infections, they take their natural course and they improve with the time. Okay, and Sanjay, do you want to contribute anything about any contraindications or precautions to the use of oseltamivir?
I have not found any specific contraindications to the use of oseltamivir unless a person has like a hypersensitivity or something. But otherwise, hardly any contraindications. The only precaution being to be taken after food, as you rightly said, it needs to be retained in the GIT.
And then, of course, there have been other few cases of influenza A, H3N2, and I just had enlisted them in this presentation, but they are the ones either, where they had some other problem, underlying problem, like asthma, and they were on meter dose inhalers, but then, they presented with, influenza. So, in general, the take-home messages for our colleagues would be that one has to try to diagnose influenza properly, and you have to treat children early to prevent flu complications and use oseltamivir empirically if required to prevent lower respiratory tract complications, hospitalization, and antibiotic use. And WHO, the American Thoracic Society, and the Ministry of Health and Family Welfare have all recommended the empiric use of oseltamivir. Of course, remember that complications of influenza include the respiratory complications like otitis, pneumonia, the exacerbation of pulmonary conditions like asthma and acute laryngotracheal bronchitis. And of course, many children they require assisted ventilation. We have seen children with influenza coming with toxic shock syndrome, myocarditis, myositis, which is at the root of this, muscle pain and inability to walk, which is more common with influenza B in the age group of 6 to 9 years, particularly in boys. And right from our residency days, we have heard of, influenza children being given salicylates, developing Rye syndrome. So it is one of the important precautions not to administer salicylates for the control of fever. And of course, vaccination against flu is very important. We all know that a child who is under the age of 9 years receives 2 shots of flu vaccine to begin with, and at an interval of 1 month. And then annually everyone is supposed to have this particular flu shot. And I recommend that it is taken on the day of happy birthday, because when we say happy birthday to you, it is easy to remember happy birthday to flu. And not only for the child, but for his sibling, for the parents, and for the grandparents. So it's a family vaccination. And try to remember that everything in flu is very fast, because the alphabet F in flu itself is for fast. Okay, so fast and furious. So the onset is abrupt, the transmission is high, the progression is rapid. A child develops, complications very fast. In case if you neglect and child develops complications, gets vertical discharge very fast. And oseltamivir also has to be used very fast. Okay. So also remember to take all the precautions. We have now, we are aware of this SMS, and we also are aware of the etiquettes related to cough, like coughing in the elbow, and also the Hasta Pancha Sutri related to hand wash, avoiding the handshake, using the handkerchief, keeping others at a hand's distance, and avoiding hand touching. So these are all the preventive measures. And with that, I salute with Namaste. And let us develop this habit like our Prime Minister, who also, wherever he goes, will always, with folded hands, put across his arguments, comments, and discussions to the other person. So, with that, I thank you for a patient listening. And remember that flu can be controlled only with your participation in the control measures and therapy, because flu ends with you. And that is why our knowledge, our upgradation of knowledge, and awareness about the use of medications, vaccines is something that is really, really important. And remember to please, at least after today's program, if you ask me, one thing that one should remember is that it is not very difficult to diagnose or suspect flu, but call them for follow-up after 4 or 5 days. Do not just assume that they will be all right, because you really don't know what happens to these patients when they don't turn up after 4 or 5 days. And as a part of what you say, a social gesture, just maybe you can decide. Of course, it's a personal suggestion not to charge them for the first follow-up. Okay, at least when they come for fourth on the fourth or the fifth day, you can charge them when they come after 10, 15, 20 days or for some other illness, because when they come on fourth or fifth day, you are learning. Okay, you are learning. And a doctor is the one who should always continue to learn. Okay, at least at my age, I have the right to say that. So one should continue to learn. I have been always a lifelong learner, and I'm sure Sanjay, who is a brilliant pediatrician, he's also a lifelong learner. So as brilliant academicians and clinicians, one should always call these patients for a follow-up, so that we know that the child is not developing some complications and he doesn't have anything else but only influenza. With that, I thank all our listeners for a patient listening. Thank Dr. Sanjay for his brilliant answers and valuable inputs, and hetero Dr. Prashant and Dr. Samruddhi for giving us an opportunity to interact with our colleagues. Thank you.
Thank you, sir. Thank you very much for your inputs. Thanks, Dr. Nato. It was lovely webinar. I mean, and the inputs that people have got, certainly, and that too in a very witty way. We don't even realize what we have learned in a nice way. Thanks once again. Thanks all the audience for taking time to attend this. And thanks Heatro team, marketing team, the sales team, and IT team for their support. Thank you very much, and we can sign off. Thank you. Wish you a very good
Thank you.
evening.
Thank you.
Thank you.
Thank you.
Okay. Bye.
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 Bye. Thank you, Nagadevi.
Okay, sir. Thank you, sir.
Thank you.